So the next speaker is Dr. Ashok Sharma, and he is going to own pediatric keratoplasty. He is a renowned expert in this field and made substantial contribution in the management of corneal opacities in children. Sir.
Good morning, everybody. I would like to thank Dr. Rishi Raj for making me part of this very important symposium, and along with the stalwarts like Professor Jagatram and Professor Emma Dogra and my other colleagues. I will be speaking on pediatric corneal transplants and presenting my experience, how I have evolved and how to get the results. I don't have any financial interest. Corneal transplant surgery has gone sea change after we have completed 100 years of first corneal transplant in 1904. There are several newer techniques of deep anterior keratoplasty and endothelial keratoplasty they have been developed. And 10 years success rate of penetrating keratoplasty in adult is very good. But the problem is that in children, still the penetrating keratoplasty or corneal transplant surgery as such remains a challenge. That is because of the ocular dysgenesis, and most of these patients, they have like the eyes may be smaller, and these children, they have low scleral rigidity, shallow AC, forward displacement of the iris and lens during surgery, high risk of iris prolapse, lens extrusion, suprachoroidal hemorrhage. All these complications, intraoperative complications, make this a high risk surgery. Increased risk of graft rejection in children is again a problem. Visual rehabilitation is arduous because they need anti-amblyopia treatment, and then children are very poor to cooperate for examination. We need need EUS to make sure that everything is going in the right way. And long-term pediatric corneal transplant results we have very limited information. If we look at the indications, we have, broadly speaking, two groups. We have congenital and acquired. It's very evident that the congenital group has poorer prognosis in terms of visual outcome as well as graft clarity because of multiple issues in these eyes. And in acquired, we are much better. And because the child has already seen, eyes are larger, so the results are much better in this group, basically. Whenever I have a child who need this kind of surgery, we have all these detailed examinations, history, antenatal and ophthalmic examination, family history, pediatric examination. And then most important for me is examination under anesthesia to make sure that whether we can help this child with the corneal transplant and what size of corneal graft we will require. Special investigations are also required to make sure the anatomical integrity as well as the visual outcome in these patients. Parents counseling is of paramount importance because it's only if the parents are aware, then only we will be able to get the desired results, and their expectations need to be realistic because we cannot be successful in every case because of all these complexities which I have already discussed. Timing of the surgery, for me, it's as early as possible, and as early as parents are ready and anesthetist is ready, I am operating. I have operated a child of 2 months also with good results. These difficulties we have already discussed. In surgical plan, basically in infants and in children, we require 6.0 to 7 millimeter diameter graft unless we have a ophthalmic eye. Then the donor graft is oversized. Interrupted sutures I use in younger children. Running and combination may be in the older children. I always go for donor corneas with good endothelial cell count. I don't operate a child unless we have more than 3,000 cell count. I make all the measures to keep the intraoperative positive pressure very low. So we give even IV mannitol, hyperventilation, flaring pre-placed sutures. But one thing which I have started doing is that I do digital massage after general anesthesia and ask my general anesthetist to make sure that I can do that, so that the pressure is low. And post-operative treatment, of course, these require antibiotics and frequent steroids and frequent EUA also. This is the result. More than 50% of our children, they had better than 660 vision. We have complications also. These children, they get sometimes injuries, graft rejection, infective keratitis, glaucoma, neurotrophic keratitis, and all that. Before I go ahead, I would like to present the details of this child who was operated by me in 2000. 17. She was brought to me at the age of, sound please. Brought to me at the age of 4.5 months, and then we like examined her under anesthesia also. She had microphthalmia, microcornea, and sclerocornea, opaque cornea. So, but even after examination, we could not fit this child under any known syndromes. And once we advised surgery, we discussed everything with the parents. Her father was army personnel, and I told him.
Corneal blindness is an evil to mankind, and we need to battle. Not this way. We need to pledge and donate eyes and perform corneal graft.
Penetrating keratoplasty in the eye with microophthalmia, microcornea, sclerocornea, and opaque cornea.
The corneal diameter was 8.5 and 8.0 millimeters.
In this child, we have taken all measures to keep the intraocular pressure low.
Corneal trephine was selected and partial corneal trephination was done. The anterior chamber was entered and the host cornea was excised. The child had been given intravenous mannitol and hyperventilated. Therefore, we did not encounter intraoperative positive pressure.
But that is not in every case. We get extreme positive pressure also, and sometimes we have to do a lot of manipulations. We have to put sutures very rapidly so that we can take care of that. And I asked my anesthetist to hyperventilate the child.
Oversized was sutured using 10-0 nylon interrupted sutures. The child underwent surgery in the left eye 5 months later. She had one episode of graft rejection that was successfully treated. The child has started going to school and is able to read and play with her friends. She is able to take part in extracurricular activities. There are many success stories similar to these.
So we have another group of like congenital glaucoma with corneal opacities where we have performed corneal transplants and we have been successful. Only problem is that because of the glaucoma, AGV valves or trabeculectomy, we have higher rate of endothelial cell loss in these patients, and keeping pressure low is again a problem. Wherever possible, we want to perform the DALK in children because that is much safer procedure and less complications, and long-term clarity of the graft is much more in higher percentage of cases. So we have results which are comparative to those reported in the literature. In the conclusion, I would like to say that PKP is a gold standard for visual rehabilitation in most of the infants and children. Penetrating keratoplasty is challenging, but can get good results if we have close monitoring and take care of complications. DALK is much safer, less invasive, and it has better graft survival with fewer complications. Endothelial keratoplasty for selected cases like endothelial congenital hereditary endothelial dystrophy is a procedure which is most of our colleagues they do who are expert in DMAC, and we have done few cases of DSEC in these children. Better understanding and prognostic factors can possibly improve graft survival time in future. Thank you very much for patient hearing.
Thank you, Dr. Ashok Sharma, for your excellent presentation. Actually, even his work has been, he has received the best poster and best paper award in American Academy of Ophthalmology. And I think this is extremely challenging to do. It is much more challenging than doing pediatric cataract surgery, because in pediatric cataract surgery, it is a bit easier. But here it is a, graft rejection. There are several of the issues.
Thanks.
Any question to Dr. Ashok Sharma?
Sir, do you give immunosuppression in these cases? Like in an adult, we don't usually give, but there are high chance of failure in children. So, do you routinely give immunosuppression in these cases, or just routine follow?
Basically, if we are giving, if we are doing first graft and there are not very high risk this thing, then we rely on frequent topical steroids. For first few weeks, it may be even sometimes 1 hourly, or then gradually we taper it off to 2 hourly, and subsequently 6 weeks, 8 weeks, then to 4 times. But it's much higher dose than in the adults. And those patients who are much higher risk, we also use topical cyclosporin and tacrolimus ointments on the eyelids to take care of that. Systemic steroids also we give, but we have not given cyclosporin to anybody, oral or